Bilateral vitreoretinal surgery in advanced stages of retinopathy of prematurity. I have slide is not moving. Okay. I have no financial interest. So ROP is a blinding disease in low birth weight preterm babies, and many of them present in late stages of ROP. So these babies need urgent intervention to prevent further damage and irreversible blindness. And these are sick babies which needs repeated general anesthesia, which is risky, and many a times they are not fit for the second eye surgery. And immediate sequential bilateral vitreoretinal surgery reduces the general anesthesia time compared to two single surgeries and timely management of the second eye. So there are different studies comparing the immediate sequential bilateral cataract surgery as well as other vitreoretinal surgeries, and they have found it as a useful modality, and that can prevent blindness in many of the cataract patients. So the rationale of the studies: performing consecutive surgeries in bilateral advancing stages of ROP leads to a delayed surgery of the second eye with poorer outcome, and these sick preterm babies are unfit for the second eye surgery, and 2 GA sessions is a risky procedure, and there is limited literature regarding the outcomes of immediate sequential bilateral vitreoretinal surgery in advanced stages of ROP. So there is a need for comprehensive study to assess the outcomes in advanced stages of ROP. So, the aim of the study is to evaluate the outcomes of immediate sequential bilateral vitreoretinal surgery in progressive stages of ROP in stage 4A, 4B, as well as early stage 5 ROP. So, this was a prospective interventional study done at RP Center of 1 year duration. At least 30 eyes of 15 preterm babies of stage 4A, 4B, and early stage 5 were taken. And all babies underwent small gauge PPV plus or minus pars plana lensectomy in single GA setting after informed consent and pre-anesthetic clearance as well as pediatric clearance. Ethical clearance was obtained from the AIMS Ethics Committee. So inclusion criteria was progressive stage 4A, 4B, stage 5 ROP, gestational age less than 34 weeks, birth weight less than 2 weeks, babies have received anti-VEGF or laser, systemically fit for general anesthesia, and parents willing to give consent for bilateral surgery. Exclusion was post-conceptional age more than 45, bilateral end stage 5 ROP, and any ocular comorbidity limiting the visibility for pars plana vitrectomy. So, after assessing the eligibility, 30 babies were enrolled, out of which 25 were meeting the criteria, and 1 was lost to follow-up, and finally we have analyzed 24 babies of 48 eyes. So they were comparative in sex distribution. Most of them were single pregnancy, and mode of delivery was mostly spontaneous. And mean gestational age was 29 weeks, and birth weight mean was 1,300 grams. And post-consumptional age mean was 37.5 weeks. And the most common neonatal risk factors were oxygen supplementation, RDS, apnea of prematurity, blood transfusion, and jaundice. And reasons for advanced stage of ROP were late screening, late treatment, and no treatment, and late referrals. And there were no cases of no screening at our Apex Center. And pre-surgery treatment, 54% had LIO treatment prior, and 41% didn't have any treatment, and few cases had LIO plus anti-VEGF prior to the surgery. Most cases had Zone 1 and Zone 2 ROP. Stages were 4A in most of the cases, and few in early stage 5. Preoperative ocular parameters, early 8% had poorly dilating pupil, and most of them had more than 7 clock hours of TRD. And we have used only 25 gauge vitrectomy in all cases. And safety parameters, all surgeons and assistants were rescrubbed in between each eye, as well as separate OT instruments as well as fluids were used in each eye. Intraoperative surgical parameters, vertical traction was released in 24%, laser augmentation was done in most of the cases, air tamponade was done in all cases, and sutureless closure was done in all cases. Intraoperatively, we had retinal breaks in 8% of cases, and most common anesthesia challenge was difficult IV, difficult intubation. And post-op anesthesia challenge was prolonged recovery from anesthesia, post-op apnea, and desaturation. So total surgical time, the mean time was 82 minutes, and total anesthesia time was 154 minutes. So time schedule, we have separated it into each compartment: mean preparation time for the I1 as well as I2, mean eye surgical time, mean rescrub time, which was 15 minutes in between the surgery, and mean surgical time for the second eye was 36, and mean extubation time was 22 minutes. So comparison, we had 154 minutes of total anesthesia time, and mean surgical time was 82 minutes, and total G exposure in one eye was 117 minutes, I2 was 93 minutes, and both eyes separately it was 210. If you had done the surgery in a single sitting, it would be 154. The p-value is highly significant. And resurgery was done in 4% of the cases, and final outcome almost 80% had regressed, and 14% was partially regressed, and 6% had progressed. So these are the cases of stage 4A and 4B cases which has been regressed. And so to conclude, immediate sequential bilateral vitreoretinal surgery allows timely surgical intervention in both eyes in advanced stages of ROP, reduces the GA surgical time, as well as proper safety precautions has to be taken to prevent infection. So I recommend immediate sequential bilateral vitreoretinal surgery is a feasible option to manage bilateral progressive advanced stages of ROP. Thank you.
So I have a question for you, that why the bilateral surgeries are not wrong. You really don't want it to happen in both the eyes.
Yes, ma'am.
So what is the rate of infection at your center?
We had 0%
At your center?
At our center, in my case series, we didn't have any infection.
No, what is the generalized rate of endophthalmitis in your center?
It varies depending upon the surgery type of surgery also. It is less than 0.01% probably, or even less.
See, we are dealing with premature babies.
Yes,
and if we are avoiding the induction of the GA twice,
Yes.
but we are surely prolonging the duration of surgery in one sitting itself.
Yes.
So it's like it's a risk-benefit ratio. And God forbid, if any infection happens, then you are jacked up with both the eyes.
There are many case series of bilateral, even cataract surgeries being done in the West, not in our setup, but they have fairly good outcomes with less endophthalmitis rate. And I don't recommend it for a cataract surgery, but for a case which like an ROP or a glaucoma which needs immediate intervention to prevent a loss of vision. In such cases we can do. And our case series was advanced stages of ROP, not early stages. So
Especially when you are dealing with advanced cases of ROP,
yes, ma'am.
I see no emergency that if you are going to
Yes.
be operating the other eye in a 2 weeks gap, I don't think that it is going to really have a harmful effect on the other eye.
The thing is, most of the childs are underweight, and these are not fit for anesthesia in the second setting. Even we struggle to get a clearance from the anesthetist, and they say they have URI, they have some issues. So if you can deal in the first sitting itself, then it's better.
Prolonging the anesthesia time will also risk the
No,
premature
ma'am.
baby.
If you consider two separate sittings, the total anesthesia time was more. It was around 200 and 200 minutes. And if it was done in a single sitting, it was 154 minutes. So we have totally reduced the anesthesia time in a single sitting. So two separate induction, two separate extubation. So you are prolonging the total anesthesia, two exposures.
Do you face any intraoperative anesthetic risk? Like you have to abandon the surgery because of some
we
anesthetic
didn't have to
problem?
abandon the surgery. We had two cases which we had to shift the child to ICU care. In the NICU, we had to shift. Other cases were shifted to the ward only, not to any ICU care.
What are the average weight of the child? What is the average weight of in your series? When you-
1,500 around. Average
weight of the child.
weight was 1,500 gram, most of the child.
Very nice presentation. You said that the average GA time would be more if you add up the two.
Yes, sir.
But you are doing two separate surgeries. So the GA total duration for one surgery would be still less than...
No, sir. Actually, the GA time to induce, it takes time. If you have to maintain the anesthesia, they don't have to give additional drugs, additional induction agents. So you're just maintaining the anesthesia in a plane. So it is not increasing the risk of anesthesia. Even the anesthetist prefer to do in a single setting.
Thank you.
Thank you, sir.